pleasure and the honor to introduce you Professor Zileli. He graduated in Turkey. Then he had a lot of experiences abroad. He has been trained in Germany. He has worked also with a great friend of mine, who's Professor Benzel. I think it's a guy who really initiated a lot of neurosurgery to spinal surgery, and also with Volker Sonntag. I discovered, due to the fact that I had to introduce him, that he has been even the founding president of the spine section of the Turkish Neurosurgical Society. And I think it's a really honor to have been a co-worker with Professor Zileli during the last 4 years in the WFNS spinal section. It's unbelievable the amount of work he has done during these 4 years. Spinal surgery guidelines, publications. I want also to remember that he organized plenty of congress starting from 2007. During the last 14 years, I guess he's been one of the most active guy in the world of spinal surgery. He has been also inspiring during the 4 years the spinal committee of the World Federation of Neurosurgical Societies. He has been really always eager to work, tireless, and inspiring us with plenty of suggestions. Besides that, as far as I could attend to many of his presentations, I can tell you that beside the fact that he's a man of science, he's the author of more than 150 publications. He's also a fantastic surgeon. I've seen presenting with a real honest way the most difficult cases that we can encounter in our surgery, such as spinal deformity, such as difficult cervical cases. And in every case, I discovered a man who's clear, who has a great experience, and who has a great, and who is really honest in presenting his results. For me, it's a pleasure and honor to present you a man who is a giant, in my opinion, in the world of spinal surgery, and who's a fantastic friend. Well, I also want to say hello to Berna, his wife, a beautiful woman. So thank you for being here, Mehmet, and let's tell us something about you.
Yeah, I appreciate the nice words that Maurizio has used for me. It's my great pleasure to be with Italian friends, and then I will try to talk about that very hot subject, improving outcomes of spine surgery in geriatric patients. If you look at the normal aging, there is a trend to be more kyphotic. The toe of the persons get smaller, and then the tendency is to be kyphotic. Can we change it backwards, and then can we achieve very old persons who are still erect position, and then making useful, active daily life? But problems of geriatric spine surgery may be summarized in 3 points. One is the weaker bones. The fractures and deformities are often more deformity, kyphotic posture, and less mobility, and more comorbidities, more complications. Aging spine, degenerative deformity is mainly two subjects. The one is kyphosis, the other one is scoliosis. And there are mainly 2 surgical techniques to correct deformities. One is to place interbody cage and grafts, and then make corrections on it. The other one is the osteotomies. We must have mainly 3 concerns in surgical planning: sagittal balance, degree of osteoporosis, and premorbid diseases. So I will now try to explain 6 points, what we can make in our planning. One is the aim of the surgery, deformity analysis, sagittal balance, adding L5S1 level or not on osteoporosis and premorbid diseases. The aim of surgery must be discussed with the patient. Actually, not in all cases deformity correction is an aim of the surgery. Sometimes if there is a sciatic pain, one level small decompression may be enough. Sometimes a prophylaxis may be our consideration. Deformity analysis, because of the kyphotic posture especially, is very important. So then what is the compensatory thoracic curve, dynamic films, flexible or rigid? What is the apical vertebra, sagittal plane deformity, and others? To achieve this, we need dynamic films, supine and standing position, which may change a lot. We need to learn the sagittal balance, the measurements on the direct X-rays. These are all well known now, a very popular subject. Still, we are having more and more information on that. So then we can consider the length of the fixation, whether it is short. If it is short, no objections. But if it is long, there are some concerns. And whether we have to add L5S1 to our fixation, this is another very important point. We must try to stop at an L5. And these are the indications for adding the L5S1 level. What about the complications of such big surgeries in a very old person? There are many. One is the adjacent segment disease, the other one instrument failure and pseudoarthrosis, breakage, loosening. And those complication rates may reach up to 80%, but approximately it's about 40% in most of the series. And reoperation rate is about 36%. It means 1/3 of the patients will need another surgery in the future after your deformity surgery. Especially deformity correction with osteotomy is a major surgery, and major complication rate is about 42%. Risks are higher if the patient is older than 60 years, 2 osteotomies and thoracic osteotomy. Proximal junctional kyphosis is probably the most common complication of deformity correction in elderly. This is one example. If you make very rigid constructs in the lower lumbosacral area, then your loads may go downwards to the pelvis, and then sacral fractures, so-called sacral insufficiency fractures may happen. I will show you some examples. This is one patient. The plan was to make a shorter fixation, but it ended just below the deformity level. So it needed that the patient needed a second surgery with lengthening and passing the deformity. This is an adventure with lumbar deformity. This patient had consecutive 3 different level proximal junctional kyphosis, and it started from the lower lumbar level, then thoracolumbar junction, then upper, then went up to T3. Osteoporosis is another big concern, and then in case of severe osteoporosis, we must use screws with larger diameters, more fixation points. We must not use forceful correction maneuvers and augment bone around the screw with different techniques. Actually, this is one case that I have done at the upper level cement injection and 2 levels up, which caused no correction loss in 3 years follow-up. Pre-morbid diseases is another concern because those elderly patients may have many major systemic diseases, and to predict the worst outcomes, this is a paper from 2007, gerontology, the modified frailty index. Frailty means exhausted. Actually, some very elderly patients can be exhausted. This is one study from 2018 who were saying that in surgery after thoracic or thoracolumbar trauma, if the patient is frail before surgery, the complication rate is quite higher, 33%, and even 30-day mortality rate is quite higher than non-frail patients. So then, frailty defining criteria is important. We must ask the geriatric physicians to measure that, and we must form our pre-operative management according to that. Recent trend is MIS surgeries. Yes. And for instance, the major complication in this study from 2014 with MIS surgery is lower than open surgery or hybrid surgery. Open surgery, this study says that if sagittal vertical axis is more than 100 millimeter, if more lordosis correction is necessary, and if osteotomy is necessary, then open techniques should be used. The other way, it's better to use MIS techniques. So in geriatric patients, before surgery, you can measure the osteoporosis and use teriparatid, more mobilization. Premorbid cardiovascular problems may be evaluated. Lack of mobility may be rehabilitated. And very common complication of geriatric patients, the postoperative delirium and depression must be measured and managed by appropriate measures before surgery and during surgery. So in general saying, in conclusion, these patients may have very high complication rates, major complication rates about 50%, and the operation rate is about 35%. And we must try to be as short as possible, and we must try to avoid L5S1 fusion. And in conclusion, you can have very nice radiological views at the end in a deformity surgery of a geriatric patient, but the patient may develop delirium, depression, and psychosis, and the patient may not be mobilizing even if you provided a good correction, maybe frail, exhausted. So it is possible, but with good selection and good planning. Thank you for listening to me. Are you okay?
So I didn't hear you.
No, you didn't all the talk? You didn't hear all the talk?
Yes, I heard everything you said.
Okay.
But I don't know what I am supposed to do now.
The talk was not released.
Mehmet could receive some question by other people attending to the meeting. My most important questions are related to which are the perspective, in your opinion, when we are talking about correcting degenerative lumbar disease? Because we started with a lot of enthusiasm in correcting spinal deformity, thoracolumbar spinal deformity, but we have been deceived in many cases in spite of being convinced of achieving a proper correction of the sagittal balance. This is the first question. And the second one is related to the treatment of occipitocervical deformity and mostly about C1, C2 deformity and Arnold-Chiari deformity. Do you agree about this subject with Professor Goel? So my two main questions are, what is your opinion about the future of deformity correction in thoracolumbar spine? And the second one is your opinion about the C1, C2 surgery for correcting any type in some way of occipitocervical and C1, C2 deformity.
Yeah, good. Yeah, let's come to first question. Actually, in case of lumbar problems, if there is some instability, I try to be as short as possible. If a fusion is necessary, I try to be as short as possible. But if it is necessary, then you must look at all the parameters and then make a very nice planning and then tell the patient that a revision surgery is possible in 1/3 of the patients. I tell all the patients that I will make 10 levels of fixation for you to make you erect, and you will get less back pain. You'll walk without anti-flexion posture. You'll be more happy, but there is a big possibility that you may have some other surgeries in the future or revisions. Without that, I don't accept them. And I learned recently especially from geriatricians, that we must also look at the other things, and that ERAS protocols we must follow, and we must be very careful about the premorbid diseases. Second question for Chiari, if there is no instability on the occipitocervical junction, fixation of a Chiari patient is still a debate. I make an analogy with that. Actually, do we need to make a fixation for all lumbar spinal stenosis patients? No. Most of them we do just a decompression. But if there is significant instability, we add some fusion surgery. And we know that fusion surgery may have more complication rates than simple decompression. This is very similar to that position, Chiari syndrome, with or without instability. But the future will show us more evidence on that, I believe. Thank you.
Mehmet, this is not a real question, but just looking into the future, on which subject would you focus your attention for a possible great improvement in some spinal disease improvement? Which is the type of surgery that you think that we can really improve by any means in the next future? If you say, for instance, that 1/3 of the people will undergo revision surgery, this would not be so acceptable in our world. If you tell to a patient 1 out of 3 will undergo subsequent surgery, is something that I think is not so acceptable. But beside the degenerative deformity, which I think it's a crucial point in this aging population, there is some other subject that you would focus for in the next future for the young guys to deal with for possible evolution, possible improvement?
Yeah, probably the biologics will improve. Actually, the fusion enhancer and some disc regeneration enhancers may have a role in the future. But we were telling that in spinal cord injury regeneration in 20 years before, and still we don't have much improvements. So then this is just like a wish, actually. I wish in the future we will have some biological tools that will replace some crude surgeries. We must be honest with the greatness of our surgeries. I mean, these are very major surgeries, especially the osteotomy. Osteotomy, in every osteotomy, average blood loss is about 1,500 milliliter with multi-level fixation. So then a 70 years old, 80 years old cannot tolerate this. So then probably minimally invasive surgery techniques will also replace some of our current surgeries. But then we are facing a problem that the education or training of new surgeons will be a dilemma for us. How come?
Okay.
You all learn this at the age of 60 or 70? This is
okay.
Thank you.
Well, thank you very much, Mehmet. I think that we can move to the next section. And I compliment you for not just for your presentation, but for everything you've done in our work. Thank you, Mehmet.
Thank you. Bye. Bye.